started, I want to welcome you to the 13th, hard to believe, Huldrych-Kammer Lectureship in Endocrinology. For those of you that are a bit younger, remind you who Dr. Kammer was with respect to his legacy. He was the first board-certified endocrinologist in the state of Oregon. There was no endocrinology at the medical school. In fact, the medical school had few to no subspecialists of any kind in 1949 when Dr. Kammer arrived. He bridged the gap between the community and the university, continued for 50 years to serve the community as a consultant and an academician and a teacher, winning multiple teaching awards. And so this lectureship is in his memory. It was his passion, it was his hobby, it was his vocation, it was his avocation to keep us all appraised of the latest and greatest in endocrinology. We want to thank the family who continue to support the endowment, and thank Kelly Beekler and the foundation for providing all the logistics that make this happen. And Elizabeth will introduce this year's distinguished lecturer. Thank you.
Pleasure for me to introduce today's speaker. She's been such a joy to spend time with over these past couple days. Dr. Jennifer Sipos is an associate professor at Ohio State University. She did medical school training and residency training at Wake Forest, and then went on to do her endocrinology fellowship at UNC Chapel Hill. She has been teaching faculty, residents, ultrasound techniques, thyroid management. She has a distinct interest in thyroid nodules and thyroid cancer. Today she is going to be giving us an update on thyroid nodules and cancer. There's been a lot of updates and new information out there around the management of thyroid cancer that I thought would be important for us to learn about, and I'm really glad that she's here today. Thank you, Jennifer.
Good morning, everyone. It is truly a privilege to be here with such a distinguished lectureship. When I saw the list of previous lecturers, I felt like I didn't even belong on the list. So I'm truly honored to be here. I know Dr. Kammer was truly an amazing individual, as you've heard, was a pioneer in endocrinology in the state of Oregon. And when I reviewed his previous accomplishments in his writings, it's really quite remarkable to see what he did and the pioneering that he did in the field of endocrinology. This is one of his papers that really truly has impacted our management of patients with Graves' disease and how we approach them. For patients with Graves' disease, often will achieve a remission, and he was one of the first to acknowledge that and to show that short-term therapy can induce a remission in a significant number of patients, and this is something that has altered the way we manage these patients. And he was also one of the first to recognize that radioiodine therapy can cause sterility in males in this paper that was dated from 1959 in JAMA. And this is something that's near and dear to my heart because I have a particular interest in radioiodine damage to patients with thyroid cancer who receive treatment. So I just want to again thank you all for allowing me to be here, for inviting me to be here, and I want to thank the Reverend Christine Dungan for all of her support in this lectureship. And we really had a wonderful time hearing about her father last night at dinner. So thank you all for supporting me in that way to allow me to be here. So in way of disclosures, I have two disclosures. I am a consultant for Genzyme. I won't be speaking about anything related to any of their products. And my institution does receive funding for a molecular test from the University of Pittsburgh Medical Center. Thyroid nodules are an extremely common entity. If we look at screening tests with ultrasound or at autopsy studies, what we find is that thyroid nodules are increasingly common with patient age, such that if we see a 70-year-old woman, approximately 50 to 60% of her peers would have a thyroid nodule if we went looking for it. And this is a very important piece of information that I share with my patients when they come into my clinic, because then inevitably, when they come into the cancer hospital to see me, they're all very, very nervous because they think they all have cancer because they had a nodule that was identified. So I will use these numbers to reassure them that many of their peers have nodules, and especially in the patients over the age of 60 and 70, it's the majority of those patients who have nodules if we look hard enough for them. And fortunately, most of them are not cancer. But if we look at the prevalence of nodules on examination that are identified, not with screening tests, but just with palpation of the neck, you can see that it's very low frequency with which we find thyroid nodules. So does this mean that we're not looking hard enough, or are we terrible at examining the neck? The reality is, it's not that we're that bad at examining the neck, it's just that the location of many of these nodules are difficult to identify. This is a retrospective study of patients known to have nodules, and what they did is look at the frequency of identifying nodules based on size. And what you can see, as you would expect, those nodules that are small, less than a centimeter, most of them are missed on palpation. But even when we get to nodules that are larger than 2 centimeters, many of those nodules are still missed. Up to 42% of those nodules are missed. Now, 2 centimeters is a pretty decent sized nodule when we're talking about a mass in the neck. So why is it that we can't feel those? So I'm going to orient you here. This is an ultrasound of the neck, an ultrasound of the thyroid. This is the front of the patient's neck, the posterior portion. The right side here, this is the carotid artery. And then the trachea, this big black structure. In between the carotid and the trachea is the thyroid. So this is a very normal, healthy thyroid. And if you look at the anterior contour of the thyroid, it is sloping away from your fingers if they're up here. So the normal contour of the thyroid is usually not palpable. Now, if we throw a nodule in there, this is the left lobe, so this is the trachea, the left lobe of the thyroid's over here. There's an anteriorly located small nodule, but you can see that it displaces the anterior contour of the thyroid, and it's therefore palpable. When the patient swallows, you can feel it bump up against your fingers. And so these are just another couple of examples of some palpable nodules. This one's much bigger, but it's displacing anteriorly the contour. And again, a smaller nodule, this one's just about a centimeter, but it is palpable because that anterior surface is disrupted. Now, these are some examples of decent-sized nodules that are not palpable because this anterior contour is normal. So here's a patient with a multinodular goiter, and none of these nodules are palpable. There's a nodule here, and then this posteriorly located one is hard to identify because it's the same color or echo texture as the normal thyroid. So this is called isoechoic. And then here's an example of a hypoechoic nodule. This one's about 1.5 centimeters, and it is not at all palpable because this anterior contour is normal. So it's not just we're horrible clinicians, we can't feel these. A lot of these are just not, no one could feel them. So many of these things are incidentally detected on imaging. We often see many patients come into the ER with neck pain, chest pain, they get some kind of imaging, and then we identify these nodules. But if we do palpate something in the neck, it is recommended that we perform thyroid sonography to further evaluate that for the presence of a mass in the thyroid. Now, you're going to see a few of these slides that look like this, and these are guidelines from our governing body called the American Thyroid Association, and they just published some treatment guidelines for management of thyroid nodules and cancer, and this is what I'm going to be updating you on. These are the new changes that have been occurring in the last few years, and as they've developed these guidelines, those are the changes that Dr. Stevens was alluding to. So this is a strong recommendation that we should be doing sonography, not CT or PET scan or MRI, to evaluate for the presence of nodules in the thyroid. Ultrasound isn't as sexy as CT scanning or PET scanning, but it is the best imaging modality for the neck because of the location of the thyroid. You can really see much more about the character of the nodules. You can determine whether there's calcifications, how the blood flow looks. These are all features that you cannot ascertain on CT scanning or MRI. So when we talk about thyroid nodules, we know they're prevalent. How often are they malignant? And we don't actually know how often these things are malignant. The number that you kind of hear a lot of people throw out is about 5%. And that's probably not far off, but it's probably a little bit higher than that. So the studies have quoted from 7 to 15%. And some of this may be higher because of a referral bias. We don't biopsy ones that clearly look benign, or we don't refer these to centers that do these kinds of studies if they clearly look benign. So there may be some referral bias in here. The take-home message is probably anywhere from 5 to 12, 14% is the risk of malignancy in any given patient that walks into your office who's identified to have a thyroid nodule. Now, we can further stratify our patient by asking them just a few simple questions or doing a simple physical exam. So the presence of any one of these features, so if the nodule is growing rapidly, if the patient has detected it or a physician has detected it and it has changed in a matter of weeks to a couple of months, that's highly concerning for a malignant neoplasm, and that needs to be rushed over to either an endocrinologist or a surgeon for further evaluation. If the nodule feels firm like a rock underneath the skin, or it's fixed upon swallowing, it doesn't move, that suggests a malignant process that may have some extrathyroidal extension, and so a more aggressive process. If there's any evidence of vocal cord dysfunction, if the patient's hoarse in any way, that's very worrisome, and we need to hasten their evaluation. When you order an imaging study of the neck, and I would say sonography is the most important one to do, it's important to remember to order an ultrasound of the neck, not an ultrasound of the thyroid. If you order an ultrasound of the thyroid, that's exactly what you get. You're not going to get any evaluation of the lateral lymph nodes. With thyroid cancer, it likes to go to lymph nodes. Up to 40% of patients with thyroid cancer have lymph node metastases. So if you don't look, you won't be able to identify those 40% of patients. And that does change surgery. So if you see a lateral lymph node that looks suspicious sonographically, that will change the surgical approach to that patient. And if you don't recognize it preoperatively, then it will become an issue down the road that will have to be addressed. So we always order a neck ultrasound with evaluation of those lateral nodes, because if one of those is abnormal, we may perform an aspiration of that lymph node in lieu of any nodules within the thyroid. The family history is an important component of this evaluation of a patient with thyroid nodules. I ask every one of them if they have anyone in their family who has a history of thyroid cancer. We often think about medullary thyroid cancer as being the familial cancer, but actually papillary and follicular can also be inherited. Because thyroid cancer is so common, you need to have 2 first-degree relatives to be considered to be familial, but ideally 3. If there's 2 first-degree relatives with thyroid cancer, it's about a 37% likelihood to be familial. And that's just because of statistics of it's more likely that it's just incidental or coincidental that 2 people in the family had thyroid cancer. But if you have 3 first-degree relatives in the family, it's a 99% likelihood that it's an inherited familial thyroid cancer. So eliciting that history is very important. Only probably about 5% or less of papillary or follicular thyroid cancers are inherited. 25% of medullaries are inherited. If the patient has distant metastases, particularly lung and bone, those could be related to thyroid cancer, so we want to evaluate if they have any evidence of nodules or if they've been incidentally noted to have nodules during workup of a lung nodule. It's important to evaluate that thyroid nodule. And then if they've had any kind of history of radiation to the head or neck area, that can increase their likelihood of having a malignancy within the thyroid nodule. But it's most important in those under the age of 15 at radiation exposure. The radiation, ionizing radiation, is particularly damaging to young thyroids. So the presence of any one of these individual features increases your risk of malignancy from 7 to 14% up to 75% in a given patient. So this is someone in whom you see one of these features. We need to be talking to the endocrinologist or the surgeon about getting this patient seen quickly. Now, the downside of this is the absence of one of these features does not rule out the possibility that this patient has malignancy. So 15% we would be missing, if we only relied on this, we would be missing a significant number of patients with a negative predictive value of 85%. So we still have to evaluate these patients with further analysis of their nodule, usually sonographically and sometimes with an FNA. One of the features that used to be on that list that I just showed you was patient age. So the list used to include patient age greater than 70 or less than 20. And the less than 20 has been pretty well agreed upon that younger folks with a nodule, it's more likely to be malignant. But the age greater than 70 was pretty controversial until this study came out last year looking prospectively at a large group of patients with nodules at one center. This was at Harvard. And they evaluated all these patients with an FNA. And what they found is that the likelihood of malignancy actually decreases with patient age, such that it's a 2.2% decrease in the likelihood of malignancy per year for patients with thyroid nodules. The likelihood of multinodularity increases with age, as we would expect, requiring more nodules. The one caveat to this was they found that though patients who are older are less likely to have a malignancy, they're more likely to harbor a more aggressive malignancy. So they're more likely to have aggressive histologic variants like poorly differentiated thyroid cancer or anaplastic thyroid cancer. So we still need to pay very close attention to our patients over the age of 60 who have nodules, but we know that their risk of malignancy in any given nodule is around 12 to 13%. Now, you'll hear me talk a lot about nodule size, and that's where we use our stratification for decision making on performing an FNA. But size doesn't matter in terms of risk of malignancy. And this is another study out of Boston that looked at the risk of malignancy based on patients' nodule size. And you can see that the difference was not statistically significant, that the risk of malignancy was essentially the same regardless of the size of the nodule. Now, what does matter is nodule composition. So the more cystic a nodule is, the lower the likelihood of cancer in that given nodule, such that a completely cystic nodule is not a cancer. We don't have to biopsy those. There's 0% cancers in that group of patients. The bad news is there's not very many of these running around out there. Most nodules have some solid component. But when you see the word simple cyst or pure cyst, that's benign. We can leave those alone. We don't have to do anything further with those patients. They're not going to become anything else. The majority of patients have some cystic component to their nodules, but you can see as it becomes more solid, the likelihood of cancer increases. Now, it's important to remember as well, many of our patients have multiple nodules. They don't usually have one nodule. If you palpate a nodule on the right side of the neck, and you order an ultrasound, 16% of the time they're going to have a nodule elsewhere in the gland. So it's important to remember if you have multiple nodules, they may need multiple interrogations of those nodules. This is a retrospective study of 120 patients. And what they did was they asked the question, if we only performed an FNA in the largest nodule in a patient with a multinodular goiter, what was the likelihood we missed cancer? So if a patient had 3 nodules and we only biopsied the largest one, we missed half of the cancers. So it's important to remember that we have to biopsy multiple nodules in patients, but we don't have to biopsy all of them. It's going to be stratified based on the appearance of the nodules. So we recommend currently up to 3 or 4 nodules we perform an aspiration on those, but we're going to prioritize them not on size, but on sonographic appearance. So how suspicious the nodule looks, and it may not be the largest nodule that gets aspirated if it looks completely benign, but we will perform an FNA of multiple nodules. Anything more than 3 FNAs at one time, it tends to be a little tough on the patients. I tend to break it up. If they need 4 nodules aspirated, I'll break it up on 2 different occasions. Now I'm talking a lot about suspicious looking nodules. So what are the features of nodules that are suspicious? One of the things that we talk about a lot is microcalcifications. Those are punctate hyperechoic areas, the bright white spots in a nodule. And these are very specific for malignancy. If we look at the number of studies, there's 15 studies in this particular paper, and we look at the range, it's still a pretty high rate of malignancy associated with microcalcifications. These other features are also suspicious, but there's a lot of variability when we look at the specificity and the sensitivity for these individual features. So hypoechogenicity just means it's darker than the surrounding thyroid tissue. Most nodules are hypoechoic. Most nodules are not cancer, but most cancers are hypoechoic. So this can be useful, but it's not always useful. Taller than wide is something that we talk about in terms of addressing the growth pattern of a nodule. So a normal nodule will grow in this direction in the transverse view. If it's growing taller than wide, then that suggests it's growing against the normal growth planes, and that's an aggressive lesion. So we don't get this reported very often on radiology reports, but it is something that's being recognized as having a high specificity for malignancy. Not very sensitive. Many nodules that are cancerous don't have that feature, but when they do, it's concerning. Irregular borders, this is an important feature that we talk about when we're thinking about can you see the edges of it, and are there fingers of the nodule that are extending into the surrounding tissue, and again, suggesting an aggressive growth pattern. This is highly specific, but not very sensitive. So the problem with each of these features, and as I highlighted some of the wide ranges of reported sensitivity and specificity, part of the problem is that there's inter-observer variability. Something that I call a microcalcification may be seen as something different by another radiologist. What I think is an irregular border may not be seen as an irregular border by someone else. So this inter-observer variability introduces a bit of error here. And so this is an imperfect way, and not every nodule has one of these features, so we could miss some malignancies. So the new ATA guidelines have moved toward more of a pattern recognition approach to evaluating nodules. And this is a little more complicated than the way we used to evaluate nodules, but in the grand scheme of things, this is very helpful because the inter-observer variability is much better when we look at the overall pattern of a nodule. And fortunately, most nodules fall into one of 6 categories, which is outlined by the new guidelines. And I don't plan to go through this with you, but what we're looking at here is just there are individual features that we're assessing, but we're also looking at the overall appearance of the nodules. Is it solid? Is it partially cystic? Does it have echogenicity that is concerning? And then using that, we have various stratifications in terms of risk of malignancy and also stratifications for our threshold for FNA with one of these patterns. And so I recommend to a lot of people who do ultrasound, until they're familiar with this pattern, that they just laminate this picture and put it in the ultrasound room right next to their machine so that they can get used to stratifying nodules and deciding which one of these are concerning, which ones are not. This is a little bit simpler version of the similar idea, and this is from the National Cancer Collaborative Network from last year. And basically they said, all right, we recognize that cystic nodules are less likely to be malignant, so we're going to have a higher threshold in terms of size for FNA of nodules. So if a nodule has some cystic component, we can use a threshold of 1.5 to 2 centimeters. If it's completely solid, we use a threshold of 1.5 to 1 centimeters for FNA. And what distinguishes between these two groups is the presence or absence of one of these features outlined in yellow. So this is a little bit more straightforward, and I think a better sort of gauge for people to decide when a nodule needs further evaluation from an endocrinologist or a surgeon. Now, once we've decided to do an FNA, what are the results going to be reported? And historically, up until 2008, it was anybody's guess because pathologists had their own way of reporting the results, and the verbiage they used was not standardized. And this created problems for clinicians in understanding what did they mean by those diagnoses. And so fortunately, a group of pathologists, endocrinologists, and surgeons got together and said, we're going to have standardized reporting for thyroid cytology. And so there's 6 categories that we see. So non-diagnostic is pretty well agreed. You didn't get enough material. And they decided what enough material was as well in this consensus statement. Then benign lesions. And then they have malignant lesions, and then suspicious for malignancy. And then this group in the middle is what we call indeterminate nodules. So when they outline these particular categories, they assigned a potential risk of malignancy to each one of these. So that's the middle category here, the middle column. What you can see is, as you would expect, if somebody has a benign nodule on cytology, you would expect a very low likelihood that you missed the malignancy. So the ideal rate of missed malignancy in those is hopefully less than 1 to 3%. If they have a malignant lesion, then most of those should be malignant. And then if they're suspicious for malignancy, then most of those also are malignant. So we pretty much know what to do with those 3 types of lesions. It's this group in the middle in the red box that we're not as clear on. And so I want to focus on particularly this follicular lesion of an undetermined significance, or FLUS, and then atypia. And when they set out for this criteria, they ideally hoped that it would be 5 to 10% of those would be malignant. And so they recommended that if you get that diagnosis, repeat the FNA. What they found in clinical practice after these came out is that up to 50% of these are actually malignant. And it depends on the institution what the rate of malignancy is. So you can imagine as a clinician seeing a nodule with this AUS FLUS diagnosis, if I don't know, if I can't further narrow down the risk of malignancy in that lesion any more than 0 to 50%, it makes it very challenging to know how to manage those patients, because if it's 5%, I'm going to manage them very differently, probably with a repeat FNA or observation. Or if it's 50%, I'm not messing around with them anymore. I'm sending them on to surgery. So we need to further stratify this group of lesions. The other question is, why is there such a disparity in this particular category of lesions? Now, if we talk too about these follicular neoplasms, Hürthle cell neoplasms, what those represent are follicular carcinomas, follicular adenomas, Hürthle cell carcinomas, and Hürthle cell adenomas. So the adenomas are benign, the carcinomas obviously are malignant. What makes a carcinoma is vascular invasion or capsular invasion. Neither of those things are diagnosable on FNA. So we have never historically been able to categorize these lesions any better with a fine needle aspiration. And all of these patients historically went on to surgery. Fortunately, most of them are not cancerous, but we as endocrinologists want to send patients to our surgeons who have a high likelihood of malignancy. So I want to see most of my patients who are having surgery end up having malignancy. I don't want them having excess risk and an unnecessary surgery for a diagnosis. So this area in the red box has really been a focus of great interest in the thyroid world, trying to further stratify this risk of malignancy in these patients so that we're not sending everyone to surgery for these diagnoses. Because if you look at the percentage of these patients that they are, it's about 30% of patients with an FNA will have one of these 2 diagnoses. So this is a big group of patients if we think about all the FNAs we do nationwide. So we really want to improve how we're doing in our yield of malignancy in this group of patients. So one of the questions we ask is, well, why is there such a discrepancy in the malignancy rate? One of the issues is case volume. So if we look at a pathologist who reads a high volume of cytology of the thyroid, as you would expect, they'd be more definitive in their diagnosis. So their rates of calling something atypical is much lower than those who read a low volume of slides. And what this study also found is that these people, the more likelihood that you were to call something atypical, the lower the likelihood of malignancy. So there's an inverse relationship here, that the more you called it, the lower likelihood it was to be actually malignant. So why not, and how do we do in terms of agreement between reading these slides? So if this is a study that looked at local cytopathologists with a low volume of cytology reads and having an expert come in and read them as well, and how often do the 2 diagnoses concur? And what you can see with this atypia FLUS group is there's a very low likelihood of agreement on this diagnosis. So why not just have all experts read these? Well, this is a really interesting component of that same study where they took these slides, they had 3 of the world's best thyroid cytopathologists read these slides, and they asked them to render a diagnosis. Then they blinded them to their own diagnosis, asked them to reread the same slides bundled up, and then give a second diagnosis. Then they asked the question, how often did they agree with themselves? And you can see, not very often. And I'm not bashing cytopathologists with this. I have many good friends who are cytopathologists. This is to point out that this is a flaw in the way that we're evaluating nodules, because these are human eyes that have their own set of bias introduced with this, and they've had their own experiences of when they've been burned by missing a diagnosis and having their own bias in how they read these things. So these are the best in the world. So it's a little bit disconcerting as an endocrinologist making decisions on these FNAs. How do I manage these? Do I really feel confident with this diagnosis? And I can give you an hour-long lecture on why this occurs and what else we can do. But the take-home message is that where we're headed with thyroid nodules is to an era where everybody else is headed. That's personalized medicine, looking at molecular markers, trying to understand the pathogenesis of this disease so that we can then use that information to diagnose which lesions are malignant, which ones are clearly benign. So we're using this for both diagnosis, obviously pathogenesis. We're using this for therapeutic targets already. We have 4 FDA-approved drugs for thyroid cancer that is refractory to standardized treatment. And so that's using this understanding of the molecular pathways of thyroid cancer to try to target these lesions. And we're also starting to use this prognostically. So fortunately, these markers can be identified on cytology. So if I do an FNA, I can look for the presence of any one of these very common mutations. And the presence of one of these common mutations assigns a higher risk of malignancy to a nodule. And that can help me decide how I want to manage them. So we're familiar with RET-PTC, with papillary thyroid cancer. The presence of that is highly specific for the identification of a malignancy. The presence of BRAF. BRAF is the hot, sexy new thing that everybody's talking about in thyroid cancer. And so the presence of BRAF is highly specific for identifying a malignancy. Then if we talk about RAS, RAS is prevalent in a lot of follicular lesions. The bad news is it's present in both benign and malignant lesions, so it doesn't help us as much. But the presence of one of these mutations can help us to decide, all right, this is someone who needs to go to surgery. The bad news is the absence of one of these mutations still doesn't tell me if the patient has a malignancy, because about 15% of patients will not harbor one of these 7 mutations. There's 7 mutations because there's 3 different kinds of RAS mutations. So the absence of a mutation doesn't rule out the possibility that the patient could still harbor a malignancy. So they still have to go to surgery. So there are some commercially available diagnostic molecular tests that are available. And I've listed them here. There are actually a couple more that have been brought out, but they're not really ready for prime time. So the 7-gene panel was just looking for those mutations I showed you on the cartoon before. This has been improved upon by the ThyroSeq testing, and this is just a broadened panel of mutations that the folks at UPMC created to improve the sensitivity so that they included more types of mutations in hopes of identifying more malignancies. And so this is currently undergoing multi-center testing. It's been tested in one center, and it looked promising, but it needs to be tested rigorously in other centers. So that's ongoing right now. So this ThyroSeq is available commercially, but I don't think it's quite ready in terms of knowing what the likelihood of missed malignancy is in these lesions. The Veracyte Afirma test is commercially available, and this has also been tested commercially, but it's been tested in multiple centers across the US. So if we take atypia flush lesions and we say the assigned risk of malignancy with those is between 0 and 48%, so the average of that would be 24%. When we look at how this test performs, what it's doing is trying to identify which lesions are not cancerous. So the previous testing I was talking about was kind of a rule-in test looking for the presence of a mutation to say this nodule is cancerous. This testing is looking at a panel of genes to identify the pattern of expression of benign lesions. So it's a rule-out test. It's trying to identify which ones are not cancerous. So with this testing, we can do it on an FNA. If the absence or the presence of a panel of gene expression looks benign, the identification of a benign pattern then has a negative predictive value of 95%. So we can feel comfortable that if the patient has this testing and it looks like a benign pattern, that this is probably a benign lesion, and then we follow those patients moving forward. So this is currently in use across the US, and this has helped a great number of patients to avoid surgery. Now the downside of this is, if it doesn't look benign, it looks suspicious. So suspicious lesions, most of them are actually not cancerous. Only about 40% of them are cancerous. So we're still sending a lot of people to surgery who ultimately have benign disease if they have a suspicious read on this particular test. So there are some issues that we need to address with this testing. to further stratify and improve our yield of malignancy in patients who go to surgery. So the current ATA treatment guidelines have been pretty wishy-washy on this issue, and they've gotten a lot of heat on not making a firmer stand for how we should be using molecular testing. But the reason for this non-specific verbiage is not every patient deserves molecular testing. It's not appropriate for every patient. We really need to, as clinicians, stratify our patients in terms of their risk of malignancy, consider their comorbid conditions, consider their desires. Maybe somebody just wants it out. So we have to explain when it's appropriate, what the risks and benefits are. We don't have a lot of long-term follow-up data, about 3 years worth of long-term follow-up data with the molecular test of FIRMA. And it looks pretty good, as similar to what benign cytology would perform. But we need to explain all of this to our patients. So the verbiage here is intentionally not definitive because it gives us flexibility as endocrinologists to say it's appropriate to use it here or not appropriate here. So I want to shift gears and talk about a benign FNA. What does that mean? Well, this is a study out of Italy performed by 8 centers across Italy. And I emphasize that because when we talk about nodule follow-up, most of the studies are performed at one center, and they're usually with an expert cytopathologist. This is 8 centers across Italy, and I'll say that they are excellent thyroid people in Italy, so they do have good cytologists there, but I like that it's a multi-center study, so it's maybe more applicable here to us at our own institutions. But they followed prospectively 1,500 nodules, and what they found over time with 5 years of follow-up was that 11% of nodules grew. 18% of nodules shrank. Now, these are nodules that were benign on FNA. And then 9% of patients developed new nodules, and within that group of 9%, they found 1 cancer. So this is important information because it tells us kind of the natural history of what nodules will do. And a lot of people, I get a lot of referrals for patients who have growth of a nodule. So what does growth mean? In this particular study, it was 5 millimeters of growth over 5 years. Now, if you think about a nodule, if you have a 2-centimeter nodule that you've identified in a patient, should I be doing something? Can we stay? Keep going. All right, thanks. I have water here. We're good. Nobody worry. I got this. Okay, sorry. It was me. I lit up in the bathroom. I was a little nervous. Sorry. It is, pot's legal here, right? I'm just kidding. Sorry. Okay, so 5 millimeters of growth at 5 years. Now, when we consider growth of a nodule, I was talking about a 2-centimeter nodule, that's right. So if I have a patient who has a 2-centimeter nodule, and you do an ultrasound, you see the nodule, and you do a biopsy, it's benign. Well, that nodule grew to get to 2 centimeters, right? So there's nothing to say that nodule can't continue to grow moving forward. And just because we see it doesn't mean it's suddenly going to stop doing what it did. So it's important to remember that even benign nodules will grow. But growth it's important to understand what that means in terms of significance. So from the ATA guidelines, they define growth as a greater than 20% change in nodule diameter in 2 or more dimensions. So there's 3 dimensions in every nodule. So we need 20% change in 2 of those dimensions, and it needs to be greater than 2 millimeters in each of those dimensions. So if you have a 1 millimeter or a 1 centimeter nodule, it needs to grow by at least 2 millimeters in 2 different directions. And the reason for that change, that variability in having a threshold, is that there's a lot of inter-observer variability between when I measure something and somebody else does. So we need to have concrete numbers. The other thing they use is a greater than 50% change in volume. Not many people use volume anymore, so I like the change in the diameters to give me a concrete number. So if you've got a 2 centimeter nodule, it needs to change by 4 millimeters in 2 directions for that growth to be significant. If it's less than that, it's variability from the measurement. You may want to repeat an imaging later to see if it's continuing to grow and compare it to the first ultrasound. But overall, that's not a significant growth. And if we look at the long-term follow-up, we can expect some growth over time. Now, we talk about following nodules. The reason we want to follow nodules is because we worry about the risk of a false negative FNA. There's nothing in medicine's 100%. So this is a study out of Korea, and there have been several studies that have confirmed this. But what they did is they looked at the rate of a missed malignancy in patients who had a single benign FNA. And in this large cohort of patients, what they found is less than 2% of people had a missed diagnosis of FNA. If patients had 2 benign FNAs, and there's a large group of people here, there were 0 missed malignancies. So that's a very important piece of information. Now, I'm not advocating that every patient have 2 FNAs, but it's certainly reassuring that if they've had 2 FNAs and that nodule continues to grow, it's not cancer. Nodules are either benign or they're cancerous. They don't change teams. So we're not worried that if we have follow-up of a nodule for 30 years and it hasn't really grown all that much, or if it's, even if it has grown, if it's been there for 30 years, surely that if that were malignant, it would have manifested itself. So we don't have to worry about that. And by the same token, if we've had 2 benign FNAs, that nodule's not cancer, we don't have to follow it. Now, what about this group of patients? If we stratify them further based on their sonographic appearance, what is the rate of missed malignancy? So if a nodule's benign on FNA but sonographically looks ugly, the rate of missed cancer is 20%, and another study has confirmed this at 18%. So we should be paying attention to the sonographic appearance and then deciding whether that patient needs to have further evaluation. If, however, the nodule is a benign-looking nodule sonographically and it's benign on FNA, the rate of missed malignancy is less than 1%. So the take-home message here is we need to stratify our nodules based on their sonographic appearance in determining the follow-up, and then as well considering whether they've had multiple FNAs. And we see a lot of these patients in our clinic. They've had nodules for multiple years. They've known about them since they were in their 20s, and they're now in their 50s. And they've had biopsies along the way, but they're still being followed yearly by an endocrinologist. It's probably a little bit of overkill if they've had multiple benign FNAs. Oops. So the current ATA guidelines say that those nodules that sonographically look suspicious should have a repeat ultrasound and FNA within 6 to 12 months. I do this at 3 months personally. If the nodules look low or intermediate risk, we can repeat an ultrasound in 12 to 24 months. If they've grown, we can biopsy them again at that point, or we can continue to observe them. If the nodules look very low risk, it's very much a cystic nodule with no sonographically suspicious appearance, the utility of follow-up ultrasound is not clear. We can follow them up, but we don't have to. The way I manage these patients in group B and C, typically in group B, I'll see the patient back after a benign FNA within a year. And I don't do 2 years just because I don't schedule that far out. I look at them again at 12 months after FNA. If it looks like it hasn't changed, I may say, I'll see you back in 3 to 5 years. If they come back, great. If they don't, it's okay. But they have to call me to get back into the clinic at that point because we're not scheduling that far out. But I feel like if they don't show up at that 3 to 5 year visit, it's probably an unlikelihood that I will miss a significant malignancy at that point. Now, if a nodule's undergone a repeat FNA with a second benign cytology, we don't have to continue to follow those nodules. This is a very important piece of information and can really limit the number of patients we have to see. All right, so I want to change gears and finish up with thyroid cancer. When I first started giving talks about thyroid cancer, I've always kind of mentioned the frequency of the diagnosis each year. And when I first started speaking about this about 12 to 14 years ago, this number was in the 40,000s. But in 2016, there will be 64,300 new cases of thyroid cancer. The number of deaths has been stable, fortunately, between 1850 to 1980. But the rate of rise of thyroid cancer has garnered a lot of attention in the lay press and in the medical literature. What we know is that females have improving survival rates, males have worsening survival rates. We don't know whether or not males have just more aggressive disease. It may be some of that, but also males tend to present later in the stage of their disease as they don't tend to use health care as frequently as women. But it's recognized that men have a higher likelihood of distant metastases at presentation. Now, this is a study that came out recently looking at the current rates of thyroid cancer incidence over time. And then they projected into the future, if this continues, the diagnostic rates of thyroid cancer continue moving forward, how often we will see it. And we will expect to see a doubling of the rate of thyroid cancer in the next 10 years. Now, this is all due to papillary cancers, as you can see by the white dots here. The folliculars and medullaries and anaplastics are stable. It's estimated that between 2010 and 2020, the diagnosis, treatment, and follow-up of patients with thyroid cancer diagnosed during that time will cost the U.S. healthcare system between $18 and $20 billion. So this is a big, big problem, and it's expected that thyroid cancer, if it continues at this rate, will be the third most common cancer in women. It's currently the fifth. So this is an issue that's gotten a lot of attention because this rate of rise is faster than any other cancer in humans. And this rate of rise has been witnessed in both women and men and in people of all ages, and it's been observed all over the world. So this is of great concern. What we are trying to figure out is whether or not this is an issue of overdiagnosis. And it's certainly, if we look at autopsy series and surgical series in patients who go to surgery for non-malignant causes, we'll find a lot of incidental cancers in patients who either died for other reason or went to surgery for reasons other than cancer. And depending on the study, that rate can be as high as 36%. That's a staggering number. This is 1,000-fold higher rates of thyroid cancer than what is seen in the general population of what's diagnosed. So there's a large reservoir of disease out there that's going undiagnosed. This is probably fairly similar to what we see in the prostate cancer literature. So a lot of people are arguing that we're just making more of these diagnoses of small thyroid cancers, that if a patient hadn't come to the ER with chest pain and hadn't had a CT scan of the neck and been identified as having a small nodule in their thyroid, we would have never been able to diagnose them as having cancer because it never would have come to detection if 15% of the US population dies with thyroid cancer. And certainly there's an argument for that. If we look at the rates of thyroid cancer stratified by size, what we see is that the small tumors are going up at the fastest rate. So certainly this is a component of this is overdiagnosis. But if you look carefully at this, you can see that tumors of all sizes are on the rise. So there's something else out there that's causing this increased incidence. What that is, we don't really know, but there have been a lot of postulations. One is radiation exposure. Just flying across the US will expose you to radiation. Certainly cell phones have been implicated, though they're not really well studied, interestingly. One of the things that people have really found a lot of interest in and has been getting more and more attention is if we take these graphs of when this inflection started to go up and we overlap that with when the rates of obesity started to increase, they are parallel. And so there are some folks who feel that the epidemic of obesity may play a role in this increased incidence of thyroid cancer. And certainly obese patients are 30 to 40% more likely to have a thyroid cancer than non-obese patients. And there are some other folks who believe that insulin resistance plays a role. So there's a gentleman in Brazil who's studying the role of insulin resistance and higher insulin levels in developing thyroid nodules, and he's also looking at thyroid cancer. And he has found that higher levels of insulin are associated with higher levels of nodules. There are insulin receptors on the thyroid. So metabolic syndrome may also play a role in this. We may never know. It's always kind of hard to prove causality with the development of a cancer, but certainly this is an intriguing possibility. One of the areas that we've learned a lot from is South Korea. So in South Korea, they have a national healthcare system where they can get all their testing for free. And as part of that, they get a complete physical exam. And just for a few dollars more, they can get a thyroid ultrasound. And so everybody gets a thyroid ultrasound effectively in Korea. And what they have found is that the rates of thyroid cancer have just exponentially gone up. And it's now the most common cancer in women in Korea. And so this garnered a lot of attention from the lay press, and they started publishing about it and putting out public awareness about this, because what they also recognized that even though the rates were going up in the diagnosis of thyroid cancer, that their mortality data was not improving, suggesting that they weren't helping patients by identifying these small cancers. So with this public service announcement, physicians stopped doing these screening ultrasounds, and lo and behold, their rates of thyroid cancer have come back down. So people have kind of gotten interested in this in the US, and this is a paper that just came out recently, looking at the rates of diagnosis of thyroid cancer per year, so the annual percent rate of diagnosis. And what you can see is that it was going up pretty good bit there. And then in 2006, a couple of folks from Vermont named Dr. Davies and Dr. Welsh published their seminal paper addressing this issue in JAMA. And that got a lot of attention. And then shortly thereafter, around 2009, the American Thyroid Association put out some treatment guidelines to discuss the management of thyroid cancer and address this issue. And then after that point, what we saw is a leveling off of the rates of diagnosis of thyroid cancer. Now, this is only dated up to 2011. We need to keep getting more information to see if this plateau continues or if we get a reversal, but it's certainly interesting to see that we're getting this plateau effect here. So when we evaluate a patient with thyroid cancer, we have a lot of decisions to make, and I'm not going to go through all of these. I really want to focus on surgery. So surgery historically, when I first started doing thyroid cancer, there was I would hear a lot about the debate that would go on between surgeons and endocrinologists about the extent of surgery that should be done. Prior to when I first started doing this, they were doing hemithyroidectomies in everybody. Then some important papers came out and said, patients do better if we do total thyroidectomies. So then they started doing total thyroidectomies on everybody. And at that time, we were also doing a lot of radioiodine ablation. And in order to give radioiodine ablation, you have to take out all of the thyroid. So for a while there, everybody was happy. Surgeons got along with endocrinologists, and we all agreed. Everybody was happy. So then we started to question, maybe we're not doing the right thing. More data started to emerge, which I'll show you, that maybe this isn't the right thing to be doing for our patients. So why is that? Well, one of the issues is that case volume of surgeons really impacts complication rates. And what we know in the US is that the majority of surgeons who operate on thyroids would be considered to do low volume of surgery, so less than 10 cases per year. If we look at the number of actual thyroidectomies that are being done in the US, they are being done by low volume and intermediate volume surgeons, less than 100 cases per year. Over 80% of the thyroid surgeries are being done by low and intermediate volume surgeons. Why does that matter? Because their complication rates are higher. So when we look at the surgery itself, if we look at lobectomy alone, the rate of a complication from just a lobectomy is anywhere from 10 to 11 or 12% with low and high and intermediate volume surgeons. Even high volume surgeons are associated with a 7% risk of complications. That's a pretty high number of complications. So maybe we shouldn't be doing so much surgery. When we look at total thyroidectomy, the numbers are just staggering. Even a high volume surgeon, 15% of the time has a complication. That's really, really concerning. And then these low volume surgeons, a quarter of the time, are having a complication. So maybe doing less surgery, we can cut those complication rates in half. So that's one piece of the equation. Then we look at, well, how do patients do? I mean, if you have a complication, maybe you can swallow it if you're going to give the patient a better outcome. And so this is a really large study looking at the patients who have low-risk disease and looking at their disease-specific survival over time. And you can see that there was no statistically significant difference when we look at disease-specific survival if patients had total thyroidectomy versus lobectomy. Okay, so that's an important piece of information. The other piece of the puzzle is that we're doing a whole lot less radioiodine therapy. This is from the new ATA guidelines. It's very complicated because that's a very difficult decision to make as to whether or not we should be giving radioiodine. But if you look at this group of people, there is a large percentage of thyroid cancer patients who fall into this low-risk group, and we do not administer radioiodine for these folks. People who have intermediate risk disease, we don't give radioiodine to all of them, just some of them. And then, of course, if there's the high-risk group, we routinely give radioiodine therapy, but this is a very small percentage of the group. Most people fall into this category here with a decent number in here. So if we're not giving as much radioiodine therapy, do we really need to do as much surgery? And the answer is probably not. So we need to be mindful of that, and the current ATA guidelines recommend that we back off the amount of surgery that we're doing. And this has been a really controversial issue that has gotten a little bit of kickback from folks on both sides of the argument, both endocrinologists and surgeons. But the take-home message is we are moving toward doing hemithyroidectomies again on most patients. So the pendulum has swung back the other way, which is probably a case in a lot of areas of medicine. Now, one thing I want to point out before I finish, sorry I'm running behind, but it's not my fault, it's the smoke detectors, is microcarcinomas. I talked to you ad nauseum about the incidental cancers that we diagnose. And so in Japan, they did a great study that they started about 15 years ago, where they were diagnosing people with small cancers, they were doing ultrasounds, and they were doing FNAs on stuff that we would never touch. A 2 and 3 millimeter nodule. In the US, we would never dream of biopsying those. They were. And so they were diagnosing people with small cancers as small as 2 and 3 millimeters. But they offered those patients the option of observation rather than having their thyroid removed. And a significant number of patients said, yeah, I'm gonna keep my thyroid, thank you. And what they did is they followed them with careful ultrasound moving forward. And what they found is that only a minority of patients had progression of their disease. So progression meant that the tumor got larger than a centimeter. So these were all microcarcinomas less than a centimeter. Or they developed nodal metastases, or it grew more than 3 or 4 millimeters. So any of those things occurred, they said, yep, it's time to get it out. Now, if you look at the number of patients, there is some attrition. Some of that is due to just lack of follow-up on all of these patients, but many patients did ultimately go on to have surgery for whatever reason, patient preference usually. When they did ultimately take these cancers out because they progressed in some way, what they found is there was no adverse effect on patient survival or outcome or prognosis by waiting to have that surgery. So that's very good news. These are indolent tumors. These are not aggressive tumors. So what's just staggering is that 10 years of follow-up, only 7% of patients had progression of their disease. This tells us a lot about the natural history of thyroid cancer. But we want to know who these people are. Why did these people progress? And they're looking at the molecular makeup of those tumors to better be able to predict, yes, you have a microcarcinoma, but yours is more likely to progress, so we're not going to give you the option of observation. We're going to just go ahead and take it out, versus, no, your molecular signature looks benign. We're going to leave it alone. And so that will inform us greatly as we go forward in the next few years of deciding we may be leaving many cancers alone. But what about those folks that we don't have that information yet? Who is at risk to progress? And what they found is on multivariate analysis, those folks who were more likely to progress were those who were under the age of 40 or who had tumors that were larger, so around almost a centimeter. Now, under the age of 40 caught a lot of people by surprise. You would expect older patients are more likely to have aggressive disease. I told you that at the beginning of the talk. Well, what they found in this study is that people acquire the mutations and develop these cancers when they're younger, and they keep them with them. And so those tumors that were more aggressive and occurred in a younger person were more likely to sort of manifest themselves, versus that 75-year-old woman who probably acquired her little cancer at the age of 35, and it hasn't manifested itself for the past 35 years, and it probably won't. So that's what they found to be statistically significant. So this is fueling current ongoing studies in the US. And what they have found, though the data has not been published, I've spoken with the PI, and he has said that his rate of progression in the US has mirrored this slope of the experience in Japan. So that data will be forthcoming and probably in the next couple of years, but so far it's looking promising. And what his experience is that though many patients get referred to him, and this is Dr. Tuttle at Sloan Kettering, many patients get referred to him for this particular trial of observation. So there's some referral bias here, But what he has found is that about half of patients choose observation. So it's a very interesting study to see how it's unfolding. So the current ATA guidelines and discussion of extent of surgery, as I outlined, is that many patients can get away with hemithyroidectomy or even observation, though it's not outlined in here about observation. They do talk about maybe some patients would be appropriate for observation of their small cancers rather than surgical removal. But if those tumors are less than 4 centimeters, which is a pretty big tumor for thyroid cancer, if it's less than 4 centimeters and there's nothing otherwise that looks aggressive about it, we can do a hemithyroidectomy, and we can also do a total. So this gives us a little bit of flexibility. It's not a black or white thing. We can just decide with the patient what's an appropriate surgery for them, and as a team, make that decision. So with that, I am done. I'm happy to take questions.
Jennifer, I'm a little worried about the early part. You scared me that I missed a bunch of thyroid nodules.
Yeah. Yeah. So the question is, worrying about missed nodules on exam, and should we be screening? And the answer is no, we shouldn't be screening because the prevalence of nodules is so high. The risk of cancer is still really low, and so there's no clear benefit of screening beyond just creating more work for the endocrinologists. But even in patients with familial thyroid cancer, so a true diagnosis of familial thyroid cancer, 3 first-degree relatives with thyroid cancer, it is not recommended that patients undergo screening, ultrasound. So my mom, my grandmother, and my sister all have thyroid cancer. It's not recommended that I have an ultrasound to evaluate for a nodule. Now, I don't necessarily agree with that, but there are clear studies that show that I could develop a small cancer that's not familial, and it could be a microcarcinoma, and whether or not I've really benefited from the diagnosis of that microcarcinoma is not clear. Now, with medullary, it's a different story. Those patients are treated differently, but with differentiated thyroid cancers, papillary and follicular, it's not recommended that screening is done, even in those we would consider to be high risk. So it's just keep on feeling, and if you find them, then keep working them up. Any other questions? Yes, sir.
So something like the nodules and the FNA surgery, it sounds almost like a solitary melanoma nodule. So if you have a suspicious ultrasound-looking nodule, you offer the patient just to go to surgery and take it out? Because if you FNA, then you show that the pathologists can't even agree with themselves. So if it's positive, it comes out. If it's negative, it may be a false negative. So if it looks bad on ultrasound, do you actually tell people we can just take this out and settle the issue?
Yeah.
Screw around with an FNA.
It's a great question. So the question for those in the back was just, if sonographically a nodule looks suspicious and it has a high risk of malignancy, and then you're not sure that you're confident in indeterminate cytology or even just a general cytologic diagnosis with the inter-observer variability, would you recommend just taking a nodule out? It's a really good point because when you look at that very complicated slide I showed you with all the ultrasound pictures and the different patterns of nodules, the top row was the suspicious ones, and they are associated with a risk of malignancy of 70 to 80%. So a pretest probability of cancer of 70 to 80%, you can absolutely make a strong argument to say, yeah, this should just come right out. I don't routinely do that, though my surgeons would I've established a relationship with them that they trust me. If I say something's cancer, they will take it out without a biologic or a cytologic diagnosis. But I typically will do an FNA so that I can determine what the cytologic subtype is. So is this a medullary versus is this a papillary or something even more malign like an anaplastic or poorly differentiated that may change my surgical approach. So with medullary, we do routine prophylactic central neck dissections. We don't do that with papillary and folliculars. And with anaplastic, we may not even operate depending on patient comorbid conditions. So I do an FNA so that I know what what I've got, and then that way I can guide the surgeon as to what surgery needs to be done. but it's a really good point.
You said that you wouldn't necessarily agree with not screening the patient who has it.
You heard that.
I would suggest that you're going to have a lot of trouble with these patients who are going to sit worrying about it.
Yeah,
it's
yeah.
so much easier to just
Yeah.
give them
So the point was, I had mentioned that I don't agree with the not screening recommendation in familial thyroid cancer. And the reason I don't agree with that is exactly as you said. Patients worry if they don't know what's going on in their neck. And also, I do think that I can tell my patients with a good degree of confidence whether this is something to be concerned about or not without doing an FNA. If I'm unsure, then I will do an FNA. But I also use a pretty firm threshold of a centimeter. A lot of people will do an ultrasound, and then if a nodule looks suspicious, we'll biopsy it if it's less than a centimeter. I actually won't. I'll watch it. So diagnosing those little incidental microcarcinomas is a little bit less of an issue there. But I usually do, and I actually have a genetic screening program with one of our colon gastroenterologist guys who does the familial colon syndromes. And so he sends me all his familial colon syndrome patients for screening ultrasounds. So yeah, I really, truly actually do the screening.
During the fire alarm.
That's possible.
So one of your slides, I think, showed that about 2,000 deaths occur in the country from thyroid cancer every year. Now, what's the approximate breakdown among those 2,000 in the cancer type? You know, like papillary?
Yeah, really, really good question. So the question is, if approximately 2,000 patients die a year of thyroid cancer, what's the breakdown of histologic type? When you ask folks that question, the first reflex is to say, oh, it's anaplastic that people are dying from, but it's actually more papillaries that people die from percentage-wise because it's a much more common cancer. Anaplastic only represents about 1% of all thyroid cancers, so the absolute number of deaths each year is very low. We only see, at our center, there's 4 of us doing thyroid cancer only, with a dedicated oncologist, so 5 of us just doing thyroid cancer, and with that large referral bias, we only still see about 3 or 4 anaplastics per year. And we have thousands of patients with thyroid cancer in our population, so it's very unlikely that it would be a more aggressive cancer. It's much more likely that people die from papillary because it's the most common, and then follicular is right behind it. But it's only about 8 to 10% of all thyroid cancers are follicular, so it's really the big bulk of people have papillary. Yes, sir.
Another comment about the radiation-induced induction, because the thyroid seems to be super sensitive to ionizing radiation.
Yes.
We used to radiate kids' heads, and we don't do that
I see
anymore.
those people.
Yet the incidence is going up.
Right. So the question is, can I comment on radiation exposure and risk with the thyroid in terms of cancer? The data is really, really poor, but certainly radiation exposure under the age of 15 has been shown to be associated with a significantly increased risk of cancer. There is a threshold effect for that, though, such that the dose of radiation matters. So up until a certain amount of radiation, there's an increased risk, and then it drops off because basically what happens is the thyroid just gets ablated, and there's no more risk of cancer, so those mutations don't matter because the thyroid's just killed. So there is a threshold effect. Adults that get radiated, we really don't know much about what their pathogenesis, because we're not doing screening in those people, so we don't know if they really have that much higher of a risk of malignancy. They probably do, but not that much. The big thing is that they have nodules. But again, those are so prevalent in our population that it's hard to tell how much of that is from the radiation versus just aging. And that
Frequency of CT scans.
yeah, and it's interesting that the modality that we're using to diagnose these may actually be contributing to the problem in CT scans. We will have potentially in the next 5 to 10 years a lot of information about nodules in children after the Fukushima disaster. They're doing a national screening program of ultrasounding the thyroid. So we'll determine a lot of information about the prevalence of nodules in children, the prevalence of nodules after radiation exposure, and the prevalence of cancer. But they also did a very good job with the Fukushima disaster of giving iodine to patients who were exposed, especially to children. The country did a great job of getting people out, telling them not to eat the vegetables, not to drink the water, and then giving iodine so that they didn't get the exposure to the radiation. So we'll probably know a lot more about the prevalence of nodules in children from that, but with adults we won't. Yes, sir.
I'm a radiologist and I
Hi.
specialize in thyroid.
I hope I didn't say anything to offend.
Well, just one thing of clarification. At our institution, if you order a neck ultrasound, you're not going to get the thyroid. You have to actually order the thyroid ultrasound.
Oh, okay.
We don't randomly, I routinely look at the neck nodes when we do that because the vast majority of patients don't have thyroid cancer. It's an additional expense to the patient.
Sure.
And we don't see the reason to do that. We have a neck mapping study for patients who have thyroid cancer, and you specifically want to look at the nodes.
Okay. That's really helpful to know. I mean, at our institution, a neck ultrasound does the whole thing. So, yeah, I'll definitely change the way I word that in future iterations of my talk. I appreciate that. Yeah. Thank you. Thank you. Appreciate you being here.
I'm sure the discussion would keep going and going.
Happy to hang out.
Super job.
Thank you so much.
Anybody who could go through the